Hello, and thank you for joining us today in sunny California. Here we are at the first United States focus on myeloproliferative neoplasms and myelodysplastic syndrome meeting. I have a pleasure here to joined by Dr. Raman Tiu from Cleveland. Hello, Raman.
Thank you,
Dr. Jason Gottlieb from Stanford.
Thank you.
And my colleague and friend Ruben Mesa from Arizona.
Thanks, Serge.
We have 2 days of intensive presentations on novelties and the new developments in areas of MPN and MDS. We had a first session yesterday morning on a biology of MPN and MDS that brought together 6 excellent speakers on diverse topics in this area. And Jason Gottlieb was a session chair. I think we enjoyed a lot of good topics, both on inheritance, on prognostication and diagnostic process with the new mutations that we have learned about over the last few years in MPN and MDS.
Yes, indeed, Serge. We had 5 speakers in addition to myself. We had Dr. Neil Shah from UCSF. We had Dr. Ramon Tu from Cleveland Clinic. We had Dr. Rafael Behar from UCSD. And we had Dr. Julian Maxson from Fred Hutchinson Cancer Research Center. And the field of MDS MPNs, I think they have really benefited from the recent era of discovery of mutations, starting from the discovery of the JAK2 V617F mutation in 2005. And really there has been a large number of mutations that have been discovered since that have really accelerated both diagnosis of myeloproliferative disorders, and within the context of MDS, there has also been a large number of genes that have been found to be mutated in MDS, whereas before we ever relied more substantially on just standard chromosome analysis. Within the field of MDS, Dr. Behar talked about the genes that have been found to be mutated, some at low frequency, some at higher frequency, and they are found to be useful in helping us stratify patients into perhaps lower risk groups in terms of prognosis and perhaps higher risk groups in terms of prognosis. And I think that over the next few years will help, in addition to the traditional prognostic scoring systems, in putting patients into clinical buckets in a manner of speaking in terms of their survival and risk of transformation to acute leukemia. And also perhaps help us with decisions regarding therapy, both in terms of whether patients may be more suited to lower risk therapies or perhaps also to higher risk therapies. And with those mutations, whether those mutations can help prognosticate whether they will respond more favorably or less favorably to certain types of treatments.
It seems to me that the myelodysplastic syndrome group of diseases is much more developed in sense of knowing mutations and using them for diagnostic and prognostic in particular purposes. And now we had some evidence also of influence of mutational status on response to therapy. This appears to be more developed than myeloproliferative neoplasm era, and chronic myelomonocytic leukemia being in between is following that suit. We have some papers published last year on incorporation of the mutational findings with other classical prognostic factors. We are gearing there to get with myelofibrosis, it seems. Mm-hmm. Raman, you were talking on the group of patients that have characteristics of both MDS and MPN. Tell us where we are with this.
Well, this is a really exciting time, as you said, Dr. Verstovsek, because we are really at the forefront of being able to really molecularly characterize a previously unrecognized group. For many years, we really thought that you only have MDS, you have MPN, and now I think that it's not just a morphologic classification, as Dr. Gottlieb has mentioned, that we are dealing with overlap syndromes, but it's really going into the molecular era. I think that, as you alluded to, it will be very important diagnostically. We are already seeing some signs how it seems to be affecting prognosis. We still definitely have some room to work on in terms of maybe targeted therapy for these groups of disease, which will be ideal. But I think we're definitely moving in that direction.
And for the MDS in particular, we always talk about genetic testing, mutation analysis, prognostication. Are we there yet for introduction of targeted therapies for these mutations? Looks like we are gearing there. We are identifying targetable targets, abnormalities and mutations, but it looks like there is little disconnect between what we can do laboratory-wise, mutational analysis, versus clinically what this is useful for.
Yeah, I definitely agree with you, Dr. Verstovsek, because for sure, like, I think this is best encapsulated by the cases of IDH mutants. There are now inhibitors specifically for, patients who carry the IDH mutation, and this seems to be very promising for leukemia. It would be interesting to kind of see it in the realms of myelodysplastic syndromes as well. I think the high propensity of spliceosome mutations and splicing gene mutations in these cases would certainly, hopefully, open the door for splicing gene therapy like spliceosome inhibitors. So I think this is really an exciting time.
I think that as it relates to mutations and treatment decisions in MPNs, I think one can argue a different point, and that is that if a patient with, for example, myelofibrosis has a JAK2 mutation versus a calreticulin mutation versus the less frequent double mutation, we have found that in those disorders that the common thread really is activation of the JAK-STAT pathway, and it is certainly likely that regardless of whether you have a JAK2 or MIP or CALR mutation, that it's not clear in any way that that is a prognostic factor for response to JAK inhibitor therapy, for example, with the FDA-approved ruxolitinib at this point in time.
I might add that I think it's a fascinating journey that we're taking, and I think all of these being related myeloid disorders, we're learning very much across the entire spectrum. But I think an aspect I think we'll appreciate more in the future is really how all of these mutations fit together. I think largely we have looked at approaches that have sought the prognostic implication of one mutation at a time and try to determine what is the prognostic implication of that single mutation. But I think what we don't really have quite yet is a much more complex statistical analysis of what does the entire profile look like together in terms of phenotypes and what that might mean in terms of therapy. So I think it's an exciting journey, but I think in many of these diseases it may be a little premature to decide solely on the presence or absence of single mutations, that I don't think we know quite how the whole profile of that patient yet fits prognostically.
I think the good example of what Ruben is mentioning is also what we learn about mutation in chronic neutrophilic leukemia, where there is a rapid identification in a very nice way of a colony-stimulating receptor 3 mutation that is targetable with the JAK inhibitors. But we still don't know whether this is actually going to help patients in everyday practice. Is this mutation really responsible for the disease? It seems so from the preclinical testing. But is the clinical result going to follow what we have seen in preclinical testing?
Yeah, indeed. I mean, the CSF3R mutation has been found in about 80% of patients with chronic neutrophilic leukemia, less so in atypical CML. And biologically, the different classes of mutations generally lead to activation of the JAK-STAT pathway or downstream to SRC kinase pathway. And so, at least up front, there would seem to be a potential role for JAK inhibitors or SRC kinase pathway inhibitors. But really, until you do appropriate clinical trial, for example, with a JAK inhibitor in a large number of patients in a disease that is frankly quite rare, needing a multi-center trial, we really need to establish whether the clinical responses lived up to the perceived biologic hypothesis that such medicines will work.
Now, the use of JAK inhibitors is going beyond the myelofibrosis. We had a session on the essential thrombocythemia, Polycythemia Vera. There are good knowledge about the use of standard therapies. The new forms of interference are coming along, but there is a good reason to think about the use of JAK inhibitors in PV in particular.
So it's really a very exciting era in terms of ET and PV. I think we're recognizing that our historical basis for therapy has probably been a bit conservative and a bit limited in terms of scope. we recognize as well that this is a fairly heterogeneous group of patients. So we heard at in this morning's sessions, we heard about the evolving range of prognostic factors in patients with ET, and that they exist on quite a range in terms of the risk of vascular events, the risk of progression, and their symptomatic burden. Additionally, we're recognizing that they are molecularly heterogeneous and trying to learn the implications of that. We also heard that even in areas of thrombosis, there are evolving sets of information in terms of prognosis, and a very interesting session on how the novel anticoagulants, although there is limited data at the time being, might have good use in patients with MPNs that are more difficult to manage. Now, polycythemia vera in particular, between ET and PV in general, and there are clearly exceptions, polycythemia vera is largely more problematic for afflicted patients than ET. And even amongst patients with polycythemia vera, they really have a broad range in terms of phenotype of how they're afflicted, in terms of their symptom burden, their thrombosis risk, and how well the current therapy has managed them. The current therapy, let's say, being phlebotomy, aspirin, and the selective use of hydroxyurea. At today's meeting, we really heard about two different levels of testing ongoing. There are frontline therapeutic studies ongoing between hydroxyurea and interferon that are being studied with interest, and very intriguing data regarding the second-line therapy of the JAK inhibitor ruxolitinib in patients with polycythemia vera. In the important response study, the randomized study versus best alternative therapy, that study helped demonstrate a significant benefit of ruxolitinib in patients that had failed hydroxyurea. Benefit defined by better control of hematocrit, better control of splenomegaly, better control of symptoms, in a patient that historically we recognize those patients with PV who are a higher risk, who have failed hydrea, really have a much more difficult disease and they have a worse prognosis. So very encouraging data, and I think in many ways very logical. I think when the JAK2 inhibitor era really began, many of us had great expectations that polycythemia vera would really be a natural place for a JAK inhibition, given the high prevalence of the mutation, the overactivation of the overall JAK pathway, and the recognition that by utilizing such therapies earlier in the course of the disease than we perhaps might use in myelofibrosis, there may be other unique opportunities that we weren't able to appreciate in more advanced patients.
So the field is moving from using JAK inhibitors only in myelofibrosis, now talking about chronic neutrophilic leukemia, talking about polycythemia vera, so that's very good for the patient's population. But we need more than one. And Dr. Jamieson has reviewed very nicely for us this afternoon other JAK inhibitors in the pipeline. There are two others that are being tested in phase 3 studies in myelofibrosis for possible approval. This is momelotinib and pacritinib. And one of them, momelotinib, also is being studied in patients with ET and PV. You have, Jason, some good experience with momelotinib in the past. How do they differ? What is the difference between JAK2 inhibitors? Should we expect more than one for patients in the near future?
Yeah, so I think that a common thread amongst the JAK inhibitors is the reduction of disease-related symptoms and the use of the drugs to reduce symptomatic splenomegaly. So I think that when you look across the board at the various JAK inhibitors, I think that those are the two clinically related issues that generally seem to be a common thread in terms of efficacy in terms of the inhibitors. I think where there's going to be some nuanced differences is going to be in the side effect profile, and also whether there may be a benefit of one or more of the JAK inhibitors in stabilizing or improving blood counts, in particular anemia. So patients with myelofibrosis present with, particularly in intermediate to high-risk disease, progressive splenomegaly and worsening symptoms, and also the issue of progressive cytopenias. And to date, there is not really any effective therapy for anemia in these patients. So there have been data from momelotinib in the phase 1 to 2 setting that shows that there can be improvements of hemoglobin or transfusion dependence. So in this regard, there are ongoing studies right now with momelotinib versus the FDA-approved drug ruxolitinib in seeing whether there can be some signal of improvement of anemia or difference between those two drugs. Similarly with pacritinib, there seems to be less issues with cytopenias or myelosuppression, and so pacritinib is also undergoing phase 2 trials at this point in time, and we will see what is the niche for ruxolitinib, momelotinib, pacritinib, and other JAK inhibitors. And I do think that because every myelofibrosis patient is not the same, they have their unique clinical issues, we will see what is the best fit for a patient and a particular JAK inhibitor.
Yeah, perhaps if I might comment, as I discuss this field with other colleagues in other areas, they ask, why so many medications for a group of patients like MPNs? And there really are two important reasons, I think. The first, the class of JAK inhibitors as a whole seem to have activity in a range of different diseases that might make their impact very significant, from solid tumors where there's been beneficial data with ruxolitinib and chemotherapy in pancreatic cancer, to exploratory but favorable data in anything from breast cancer to even inflammatory disorders. The second is really the lesson we've learned from chronic myeloid leukemia. We now have 5 FDA-approved tyrosine kinase inhibitors, and they really all have a potential role in patients even with chronic phase CML, let alone accelerated and blast phase, given the varying phenotype of disease and the different issues of comorbidities and overlap and issues of what is the best fit for each patient. So I share with patients, I'm incredibly pleased and hopeful for them that we likely will have a range of options, to be used either as monotherapy or increasingly in the future probably as combination therapies to more effectively deal with the nuances in patients afflicted with these diseases.
We always need more, and we learn very good lesson from myelodysplastic syndrome. Looks like we always follow the MPN follows always the myelodysplastic syndrome. And Ramon, you were telling us about new developments and new drugs in MDS. Not everybody responds, and not for too long, to hypomethylation agents or IMiDs. And there is so much efforts in developing new drugs for MDS.
Yeah, so this is very interesting. Of course, from the years of blood transfusions, it's very good that immunomodulatory agents like lenalidomide and hypomethylating agents like 5-azacitidine and decitabine became standard of practice for these patients. We have treatments for low risk and high risk disease, but obviously, as you've said, the biggest problem are hypomethylating failures. Big subset of these patients certainly do very poorly, but there's a lot of very interesting agents that are definitely coming out right now, and these agents span different mechanisms from single agent to combination therapy, single agent with PI3 kinase inhibitors to get which also has activity against polo-like kinases like rigosertib. So that's definitely a very interesting drug that can be used for this particular disease. There's also combination agents with hypomethylating therapy together with an HDAC inhibitors of various types, prasinostat and various other HDAC inhibitors that are out there like panobinostat. Also, there's a lot of interesting drugs like right now, drugs that has decreased ability of being degraded by cytidine deaminase and therefore can certainly stay longer in the system and could potentially be more active. There's also some drugs for lower risk disease, for example, orally bioavailable 5-azacitidine are now also trying to being tested at this point. So I think we have a bunch of treatments that are currently being looked at. So this will couple very well with hopefully, better predictive factors that would allow us to identify patients who are most likely going to respond.
Yes, these things go hand to hand. Mutational profiling, prognostication, and selection of the proper therapies, at least knowing what the therapies would do in an individual with certain characteristics.
I think the bar was raised with the use of tyrosine kinase inhibitors and CML with the imatinib and second, third generation drugs, where you have primarily a monogenic disease in early phases of the CML natural history. And the other example, of course, is lenalidomide in the 5q minus subtype of MDS, where the erythroid response rate and transfusion independence rates are very high. I think that raised the expectations that we would have targeted therapies that will accomplish the same in different forms of MPN and MDS. And of course, the fact is that these diseases are very genetically complex. They're very heterogeneous. And I think that what the future holds is using the molecular data, combining it with what we know these drugs can do and which pathways they hit, and tailoring certain targeted therapies based on molecular profiles and incorporating such biologic correlates into clinical trials so we know what types of patients will benefit best from certain drugs. That, I think, is the future.
I think you raise an excellent point in that I think in many ways we were spoiled by the success of imatinib. I mean, it was a tremendous story, but across cancer as a whole, it's a fairly unique story. So I think the danger, as we hear about all the different things in testing, is the potential danger of discarding therapies too quickly that might otherwise prove beneficial. In MDS, we certainly learned our lesson. I mean, the hypomethylating therapies themselves almost really got discarded until it was really learned over the first few years of practice with those agents that one needed a lot of patience and that the issues of dosing strategy made a big difference in terms of both tolerability and patience in terms of seeing an impact. So I think, Jason, you're exactly correct. I think we have to look at studies and have the correct correlates to know as we investigate things, is it truly a negative study? Were we really hitting the target that we wished? Or were we really not testing what we thought we were testing and might discard an avenue of therapy that might be very fruitful if we discard it prematurely?
And I think that certainly, I think this is where biology is really very important, just like what was shown in your group, Dr. Mesa, by your colleague Raul Tibis, where he showed basically that you could restore sensitivity to hypomethylating therapy again if you're able to target the BCL pathway. So I think this just really showcased to us kind of how biology can really help tailor what seemingly is a resistant case into subsequent responses again.
Now, at the end, we are left with the bone marrow transplant. And the common theme throughout the presentations on the clinical part was transplant as the ultimate cure, obviously, for patients with myelodysplastic syndrome and myelofibrosis. Are we making any major progress there? For example, the issue of using ruxolitinib in advanced patients with myelofibrosis to optimize their body condition before the transplant to make them eligible or sustain the transplant more, or use of hypomethylation agent in all the patients with high-risk MDS to improve their bone marrow environment, if you like, decrease the blasts and make them more suitable for MDS. Interesting questions for discussion.
It's a very interesting question, and the reality is that in both sets of diseases, we have really very few therapies available to us. So the question really isn't whether azacitidine or ruxolitinib are going to be used respectively before MF or MDS transplants, because they are as we speak. The real question is, can we really measure what that impact is? And two, what is the best strategy for doing that? So there are several ongoing studies right now with JAK inhibition before transplantation. And I think questions do remain in terms of what is the optimal schedule. Is there best to be an interruption before the start of conditioning? Do they overlap? Are there issues of dose? The preliminary data that were presented this afternoon certainly seem favorable that have been going on in studies in Germany and in France. There does not seem to be a specific toxicity or concern or delayed engraftment, but I think it's early in terms of quantifying it. We know well that people are coming in for transplant now who are already on ruxolitinib. In a field that there's only one approved therapy, it's almost natural to know that. But there really are unanswered questions. Should that be stopped at day 0, day -7? So I think much for us to learn and really for very close communication to occur.
And I should just mention now there are preliminary data with the use of JAK inhibition to mitigate the effects of graft versus host disease. And so we talk about the use of JAK inhibitors and how they interdigitate with transplant before or afterwards, talking about its effect on the disease or the natural history of the disease. But we may be able to enter an era where we're using some of these drugs to also have an influence on reducing complications, which really can affect the long-term course of these patients. So we look forward to those data as well.
And if I may add just to the transplant cases, definitely in myelodysplastic syndromes, the issue is, of course, when do we transplant these people? As you've mentioned, do we wait until their disease progresses to a much more higher risk disease, or should we transplant them early on before and don't wait for the disease to really progress? So definitely a lot of still areas that would still need to be worked on.
And these are patients who we typically use the risk factors of age and performance status and IPSS stage of disease, but this is where we also may be able to incorporate, of course, bringing back the molecular feature of the disease, and now we have several groups identifying relatively poor risk mutations, and so incorporating those mutation factors with the IPSS or DIPS plus, age, performance status, of course, suitability of a donor, these are the factors that I think that will be very useful in helping patients make decisions about high-intensity therapies such as transplant.
I agree, that's very good. So Ramon, Jason, and Ruben, thank you very much for a good summary of the meeting. We thank you all for participation online. Hopefully we see you next year at the second United States focus on MDS and MPN. Again, hello from sunny California, from the first US focus, and have a nice day. Thank you.